Right, good afternoon. Hope everyone enjoyed lunch. We're going to begin our fireside chat. What wonderful weather to actually think about fireside chats at this stage. So here we go. So as they're coming up on stage, I'm going to give a brief introduction to our MC for the fireside chat, and it's Dr. Ed Hurwitz, and then you'll be hearing from Dr. Smith and Horvitz in an open and hopefully captivating discussion on their wonderful work in learning health systems and implementation science. But let me just introduce Dr. Hurwitz, who will be moderating the chat here. Dr. Edward Hurwitz is a professor of physical medicine rehabilitation and professor of learning health sciences at the UM Medical School, and really, frankly, one of our finest champions for learning health systems in the clinical setting. So without further ado, Ed, I'll have you take it away. Thank you.
Thank you, Amy. Well, first off, Leora, JD, the talks have been fantastic. This has been an amazing, amazing day, and I think everybody would agree that we've really learned some great things. So during lunch, we were talking a little bit about, people ask a question, which medical centers are learning health systems? And is Michigan Medicine a learning health system? And what we talked about is that really any academic medical center and really any hospital is a learning health system to some degree. It's a question of what degree. So I want to talk a little bit about what does the word system mean in a learning health system? How does that apply? And, when do we know we have a system that's a learning health system?
I feel ill-equipped to answer this question. I think the multiple components, obviously, that have been talked about in Amy's talk and Leora, of having a data infrastructure that you actually use, that has pulling data and then creating charts, spreadsheets, things that actually can be interpreted, and then feeding that back and actually having that full recursive cycle really makes it something of a system, right? That whole cycle, and including obviously the people and the other pieces of the infrastructure. But it's a tricky thing because everything is a system. It's just whether or not it's actually functioning the way that it's supposed to. And I remember actually going back to, this was probably 2014, 15, something around that time when I first read about what a learning health system was supposed to be. And at the time, I was not really embedded in health systems research at all myself. I was kind of even new to implementation science. And I remember we had that as part of a journal club. And all the physicians in the room that were physician scientists were like, basically, this feels very aspirational. Like all these things feel like you could get there, but that it's a North Star that we should be shooting for. So I think that kind of dovetails back to our comments earlier in our discussion at lunch of you're always on some kind of a continuum, and there's always ways to make this function better, but where are you is probably an appropriate question at any time.
Yeah, I agree with that. And the other thing we mentioned at lunch is that it's very lumpy. So even at NYU, I would not say that we are uniformly a full thickness, learning health system everywhere you look, right? So there are groups that we've worked with for 10 years that I think really have a deep learning health system ethos. And then there are parts of the institution that just are not even close. And that's sort of normal because systems are complex and, not fully, they don't all work exactly in the same way, all parts of it.
Well, a lot of what we talked about today is about, entities within the system that come down into teams and help solve problems. How do we bring that down to the actual clinicians themselves so that these kind of things are generated not by some specialty team, but by the clinical team themselves? Clinicians often look at these things as kind of barriers, changes in the work, additional work that I have to do to enter data. So how do we work with clinicians so that they have the skills, they have the tools, they feel it's more value than burden?
Yeah, this absolutely been our gold star or North Star or whatever for years. We would like to put ourselves out of business. A real learning health system just does this stuff. Everyone does this stuff. I would say at this point, we're 10 something years in at NYU, and I would say on balance, now the projects that we do because someone comes to us. So they're still not doing it entirely on their own always, although some will, but nor are we going to them and banging on their door and saying, you really ought to do this thing. So we're kind of right in the middle there. But there's an increasing number of folk that are able to do stuff on their own. And so, for example, we just 2 years ago, I went and gave a talk to some of the senior people at H&H, which is our public hospital system. Bellevue Hospital is the flagship. They're right next door to us. And so I was talking to their QI team about the stuff that we do. And we sent them our toolkit, and they seemed to enjoy it and went off. And then 6 months later, I heard back from them and they said, hey, we implemented a trial and here's how it worked and here are the results. It worked great. So that's like a nice example of, just needing a little coaching and then being able to do stuff. And that's our goal, but they're also happy. The reality is that the clinicians are never going to have the same data access and data analyst ability, and some degree of central kind of resource availability, I think, is actually part of a learning health system and is okay. It doesn't have to all be distributed, at the local site.
I think the only thing I would add is really to actually tag on to what Deora said is a lot of the projects that I have had the best success with and have been really embraced by the systems have been physician-generated ideas. Like they really are recognizing either a practice variation or a place that, they maybe went to a conference or something and they saw something that they thought would actually address a problem that they've experienced themselves or they've witnessed within their own practice. And then it goes back to, the higher ups within the system reaches out to the research team then talks to the clinicians, looks at the data, and then you start to generate more of a, idea for an actual project. So yeah, I think even just training people to notice these things and know who to tell and that could be just an entry point, of course, not a full solution. The other thing I would want to dovetail, and I'm curious what Leora has to say about this too, is the pace of clinical trials and the complexity of even the most simple randomized trial can be both daunting and just infeasible in a lot of situations. As a methodologist or a person who's, predominantly focused on methodology and implementation science, I don't have a great solution. There are things like micro RCTs and some other things that might be quicker, rapid time periods, but they're still not easy in ways that you could just tell a clinician hey, you see a problem, go do a little thing and give us your results. It has to be an enterprise and pieces around it. So I don't know if there's a shift in paradigm or even methodology that has to happen to make this more feasible.
Yeah, this is a real challenge. And I was saying earlier that we kind of get away with a lot of that streamlining by calling this stuff quality improvement, but that does omit an enormous number of things we could be doing to learn. We should be comparing drug A to drug B and whatever. We don't do that in part because the regulatory hurdles. I think there's some fundamental changes that would be helpful. Like Nancy Cass is a bioethicist at Hopkins, and she's argued for years that that all of this stuff, even the stuff that we do, is research. We should just call it research. We're learning from it. It's generalizable. Let's be honest and call a spade a spade. It's research. But none of it should require consent. None of it should require the kind of regulatory burden that we impose on it because they're minimal risk. Patients don't usually have the choice if you're picking, one kind of catheter to use in your cardiac cath versus another one, or one arbitrary blood pressure medicine versus another one. These are things that patients don't usually have input into anyway. They're oftentimes, if we're talking about comparative effectiveness stuff, they're all FDA approved and all reasonable, and we just want to test which one is working better in particular patients. And so she makes the argument that we should not lie about what these are, but we should massively streamline the regulatory burden. And I think that would be very helpful. The NIH Collaboratory for Pragmatic Trials, which is housed at Duke, has a weekly grand rounds on Friday afternoons. You should all sign up for because they just bring in speakers to talk about their pragmatic trial. And oftentimes it's, how did we do this more efficiently, more rapidly? We're pragmatic. They're all posted online, the old ones. There's lots of opportunity also to streamline recruitment. We can do these identifications much better now with computable phenotypes and AI and so on in the electronic health record. We can set up defaults where patients are automatically notified about potential trials. There's all kinds of things we could do that we haven't built the infrastructure for.
I know that Chuck Friedman here likes to use the word discovery sometimes instead of research, because discovery doesn't need an IRB. You're just trying to discover things. Where does the learning community fit in? When we talk about some of the work that we're doing, that you're doing, Improve is doing, what about the clinicians, the team forming a learning community? Does that fit in to the picture?
It should. We have, I think, 3 studies now that I'm part of have virtual learning collaboratives or virtual learning communities. They're more or less the same thing, but if you call it a collaborative, you have to follow a model. If you call it a community, it's a little less protocolized. At least in my experience, that's been the difference. But they're all outside of healthcare. These are all we have done it through community-based programs where they're learning from each other how to implement. One that we just started is a family healthy weight management program. So there are all these community-based organizations in these micropolitan communities, which is a nice way of saying bigger cities and rural areas. But they've never implemented these before. It's brand new. We're asking these organizations to do something they've never done. And those collaboratives actually, they do learn what adaptations they can make that are still fidelity consistent. They're learning how to actually interpret the data and, obviously sharing a lot of different resources and things that they're each individually creating. It's a great way of doing things. I mean, there's no reason it couldn't be part of, an LHS, very, very centrally, but I don't know how. I haven't seen that actually happening in any of my experiences.
We don't have one. It's been also on my 5-year plan for 10 years, is to have a LHS collaborative community something. So here, we could set it up now and you could all join it. But we haven't really figured out how to do that yet.
So this is not a collaborative specifically, but I'm part of the Genomics Enabled Learning Health Systems Network, which is NIH funded and NHGRI funded multi-center project. Where we are all implementing the same exact protocols across each of the different centers. And we are learning from each other, but it's not characterized this way. I think that might have been the intent of calling it the network. But yeah, not in the exact same way. And of course, these are they were all funded for a reason. They're sort of rarefied, learning health systems across the country. I don't know. I don't know if we're, giving more money to the already rich or what's happening with that, but.
I find that a lot of groups actually are doing learning health system work and don't call it that, like you said. In my explorations and what I've been doing over the past couple of years, I talk to groups and they use data. They do try to learn from it. Their system is not complete. There's missing points. A lot of times there's not enough patient interaction, that kind of thing. But people are doing it and don't necessarily know. So sometimes it's a matter of letting them know that they're doing it. I had a couple of questions about incentives that have come through in terms of how do we work with the leadership of our medical systems, leadership of our hospitals and so forth, our department chairs, to line up incentives so that people are interested in this kind of work.
Incentives for the physicians being part of learning health system or changing practice?
Whatever needs to happen to make a greater learning health system.
Yeah, good question.
There's an economist in the audience. You just asked me this during lunch. So I think I gave a kind of utopian answer, but I really sort of believe it. So, why do I do this work? I get some papers out of it, but I will tell you honestly, the A/B tests that we do are not earth-shattering, revolutionary in and of themselves. It's not they're going to be JAMA papers. So we write about them, which is nice, but it's not enormously consequential. I don't really get a lot of grant funding for this kind of work because NIH doesn't like this kind of work. They like to have 5-year-long, really complicated clinical trials that you can't change after you submit it ever. It's not really their thing. The reason I do this work is it's satisfying to me to do an intervention and have an outcome be better in pretty short order, as opposed to a 5-year-long trial that might not ever work. And it is certainly the case for the clinical partners that we have that this is true. Like, they don't get any papers or any funding or anything. But nobody wants to come to work to spend all day calling patients post-discharge and like have that not work. Nobody wants to do that. Everyone wants to come to work feeling like they're making people's lives better, and demonstrating that to them is really gratifying. And demonstrating that something doesn't work, which is actually the norm, is okay. We've learned how to kind of set this up from the beginning. You have to do a lot of expectations management because you iterate. And then they're feeling like, oh, well, this thing isn't working, but here I am really engaged in trying to now make it work. We just have not had difficulty getting people to collaborate with us over many years at NYU because that is fundamentally appealing. I mean, remember, healthcare is self-selected. Like, they could all be working on Wall Street, and they're not. So they're already people who are kind of, mission-driven, and that is meaningful. That said, obviously, incentives are massively important for the way we set up care and the things that the institution will value us working on. And that's why we talked earlier about, the de-implementation challenges. How do you get a health system excited about those? And those are harder to get a healthcare system excited about. So, policy and payment and all that stuff does matter, but the intrinsic motivation is important too, as is reputation. So, like, me being here talking about NYU is nice for NYU, right?
Yeah, I'll tell a little story that I hope illustrates this a little bit. I mentioned the clinical partner work group that we had for the pediatric hypertension project. Those were, I think, exemplifying like personal attributes and motivations that probably would translate also to kind of leadership and engagement in learning health systems. When we reached out to all of the actual community health center organizations, we said, hey, here's the idea for this potential project. We don't have funding yet. This is really preparatory work, all that kind of stuff. We said, do you have anyone that you would recommend us like reaching out to? And all the people that we got connected were people who would have done it for free. And they didn't care about like publication recognition, but they cared about changing practice. It really was like, this is an issue that I care about. And beyond that, I think that all of them wanted to be viewed as leaders in practice change in their organizations, regardless of what the topic was. We did offer them publication credit. I think all of them are on at least 2 or 3 papers that came out of that project. We did pay them because we obviously respect them. We didn't pay them enough because, grant budgets, et cetera. But really tapping into those personal characteristics and motivations. And honestly, whenever I do a project where I'm engaging with any delivery system, whether it's healthcare or otherwise, we always ask both the frontline people and we ask the leadership, what would be motivating to you? What would be incentives that you care about as an organization or as an individual, and try to embed those as much as we can. If it's just pay us to do this, like that might not be feasible. But certainly, things like getting MOCs for some of the opportunities, having the opportunity to have people get elevated to practice champions and actually, kind of have that, recognition. We try to really align those things as much as we possibly can and build it into our projects.
Leora, what your comments make me think about one of the things I try to sell about learning health systems is the burnout factor. We all know the very difficult problem of healthcare provider burnout that we're all dealing with here. And when you look at the reasons for these burnouts, often it's feeling like you're doing work that has no value. And I really try to promote the idea that the learning health system model will bring value to the work. So, Nora, do we have any other questions online, or is there any questions from the audience?
I think another thing that I'll say too about just the way that I approach the work that I do, most of my work with healthcare is in primary care. And whenever you go talk to, primary care leaders, the first thing they say is, don't ask us to do more things. And so what we actually say is, what could we do to actually make your life easier? And approach it explicitly that way. How can we save you time? How can we take something off of your hands? How can we help you do something more efficiently? And it's led to this group that I work with at Utah that's led by Dave Wetter, who does mostly cancer-related research, but not entirely that. We ended up actually getting a bunch of big grants to build the EHR infrastructure for these tiny community health centers across Utah that are part of this very cutely named organization called OUCH, which is the Association for Utah Community Health. And we literally like went out and got grants that 2/3 of a huge grant was just to build their infrastructure. And that infrastructure has allowed us to have, well, I say we because I'm part of the group, but Dave really, about 10 or 12 other large grants that leverage this population health management infrastructure to do a whole bunch of text message campaigns around, we did COVID vaccines, which as you might expect in Utah, we got a lot of expletives in response to encouragement to taking COVID vaccines. But we also have done it for colorectal cancer screening, for cervical cancer screening, for lung cancer screening, for weight management, for now we have a more recent one for quit lines, for helping people quit smoking, and they love us. I mean, we have a weekly meeting with them to go over all of our projects, and almost every week somebody has an idea for something we could try to use this for and write a grant. Like we are literally running out of like grant writing time to be able to help them in the way that they like. And I think this whole thing of like going to a system and saying, hey, there's this great thing that I developed or that just came out. We want to help you implement it and test it here. Like, I don't know. I don't love that approach. So, yeah.
Hi. Yeah. Speaking of engagement and then also kind of our commitment to human subjects, thinking of these patients as human subjects, to what extent did you reach out to the community, or is the community aware that you're doing these things? Do people say, I want to go to NYU because I know they're rapidly innovating best practice care, or is it all happening behind the scenes? Was there a deliberate engagement either before or during?
Yeah, we talk about this often. The short answer is no, of course not. Like mostly the community has no idea what we're doing. We talk often ethically about the fact that we think people ought to know this. We don't. I continue to believe that individual consent is really not necessary, but I also continue to believe that people should know kind of what we're doing. In the same way that if someone comes to an academic medical center, they know that part of the deal is they get taken care of by students and trainees and people who are not expert in what they're doing. Like that's part of the contract you make when you show up at an academic medical center. They should similarly kind of know, well, people here are continually iterating. I think there's two issues here. One is, I do think they kind of take that for granted, right? Like, of course this institution is trying to improve its quality all the time. Like, why would they not do that? That's why airlines don't compete on safety, right? Like you kind of would like to assume that they all take that seriously. So to some extent there's that, but on the opposite side also, I think actually there is absolutely no conception that work might be done in a rigorous, by which I mean randomized fashion. And Michelle Meyer at Geisinger has done really interesting work in the pre-AI days with Amazon Turk when there were real people answering those surveys, where she's created like a whole ton of scenarios and asked people how they feel about them, and found really interesting results. In fact, she's written 2 or 3 papers in PNAS, and the first one's called something like "Objecting to Unobjectionable Tests" or something. As an example, she'll give people a scenario like, doctors would like to avoid bloodstream infections. Would it be okay if they put a poster up in a patient room about how to avoid that? And everybody's like, sure, that's fine. And then she'll say, okay, well, doctors would really like to avoid bloodstream infections. Would it be okay if they put like a little card on someone's ID badge to remind them of, how to stay safe? And everybody's like, sure. And then she'll say, well, doctors would really like to reduce bloodstream infections and they're not sure how best to do it. Like, is it okay if they put posters in half the rooms and ID cards on half the IDs? And people are like, oh, I don't know about that, right? Where they clearly have no objection to anything that you're doing, but they sort of like intrinsically object to this concept of randomization. And I'll say even there it's a minority. The majority of people still are, feeling okay about that. But that kind of community lack of understanding about that or discomfort with the concept of randomization, a lack of understanding that basically we're doing uncontrolled experiments all the time on people without, doing those controls and therefore not being able to learn from it is not in the lexicon. And there's unquestionably a substantive minority of people who would be quite disturbed by that. And so we think about this all the time. In fact, we wrote this perspective piece in the New England Journal in 2019 about our program, and I sent it to everybody institutionally I could think of ahead of time, like the comms team, the dean, the whatever, because I was like, I just want you to know I'm writing this thing, and people might see it and get really angry. And it turns out the general public doesn't read the New England Journal, so it's fine. No one complained. But we have lots of examples of Facebook running trials and Pearson testing running trials and things that really upset people when they find out. So anyway, so we do our best. I talk about it all the time. We write papers. We try to convey. We put it in our newsletter. We write about it in the whatever fancy brochures we send to patients. We do our best to make it known. But I guarantee to you that 99.9% of people have no idea that we're doing this, and that some of them would be quite upset.
Yeah, I have two examples that I think answer your question a little bit. One of them is I've been working with an intervention for parents that we're now implementing in primary care that's called the Family Checkup for Health. It is an evidence-based program. It's on every list. It's part of the home visiting McVie funding, so it's bona fide. And one of our pitches, and one of the things that healthcare organizations who are potential adopters and ones who are allowing us to do implementation in their organizations, they want to be able to say and advertise that we offer this, right? Because most behavioral health, you don't know what you're getting most of the time, and even when you go get it, you don't know what the name is, or there's no recognition of this as a thing at all, right? So they actually see that as an incentive for them to be able to say, hey, all of our people are certified. You're gonna get a certified, named intervention, and if they try to use it to set themselves apart from their competitors. We don't necessarily talk about that it's part of a trial per se. There's always opportunity. Once they're actually there, in this instance, we do have opportunity to have additional assessment that we pay for. That is clearly the research, but we don't tie the provision of clinical service to participation in the research. So you can decline to do any of the research, and we often offer multiple levels of engagement in the research, where it's kind of a light touch, a more invasive. I say invasive, don't tell my IRB. Kind of just a much more burdensome assessment. So in that way, it works pretty well. We have another trial that's happening in Southside Chicago that Amy's aware of because it's part of our Decipher network, which is about disparities elimination. And we have 16 community health center primary care practices, all within a pretty tight geographic area, that we randomized half of them to get a standard implementation protocol for the Kaiser Permanente blood pressure control bundle. And the other ones got the standard intervention plus practice facilitation. Well, we had determined, and we successfully were able to get the IRB to say, practice facilitation is not a patient intervention, so there's no reason to disclose that. But what we do in the community is we tell them there is a blood pressure control effort or initiative that's happening at all of these health centers. If you haven't been to your PCP lately, go check it out. Or if you're concerned about your blood pressure, or if you have high blood pressure. And what we have actually found, which was not even a primary or even secondary aim of this project, is we are getting more people to go to visits who haven't been in years. We are identifying through our actual study procedures people who have undiagnosed hypertension, just because we're raising the awareness, and then we're basically saying, oh, you should go see your PCP and get this diagnosis confirmed. So we're advertising it as be part of a study that is also a community-based blood pressure control initiative. So there's kind of a weird fine line between advertising and I don't know if you want to call it a recruitment strategy, but yeah, it's definitely try to make people aware, because I think sometimes these kinds of things do actually set those systems apart and draw business for them, which they appreciate usually.
Question?
Oh, sure. Hi, I'm Zoe. I'm a student in the Department of Learning Health Sciences, and I want to apply the LHS framework to reducing alert fatigue. This question is for Dr. Horwitz. You had mentioned that at NYU, kind of a handbook for kind of getting rid of old alerts. So I was really curious to maybe have you speak more on that and how you're able to kind of scale that across clinical units and even kind of different practices at NYU.
Yeah, so first we have a toolkit for how to do A/B tests in general. And separately, we have a whole set of projects around trying to make alerts go away. So the first thing that we do is we pay close attention to who is getting the alert. So like we talked about with the flu vaccine alert, like we don't need to be telling the anesthesiologist to get a flu vaccine. And we've done a whole bunch of interventions just on that. This makes people anxious, right? Because they feel like, well, if I give the alert to more people, it's more likely to happen. And so that's why they get set up in the first instance to go to lots of people. So we had a venous thromboembolism alert. Make sure you order, blood thinners to stop people from getting blood clots in their legs. And it went to everybody. It went to the nurse, it went to the attending, it went to the intern, it went to the whatever, because this is very important. We'd really like people to not get blood clots in their legs. But only one of those people actually puts an order in for blood pressure, for blood clotting, and that's the intern. So we did a randomized trial. We're like, okay, what if we turn it off for everybody except the first contact provider, the person whose actually job it is to put the order in, and we'll test it against sending it to everyone, because maybe the intern will just ignore that, and it's really important to tell the attending because they're ultimately responsible. Like, we don't know which is better, right? So we randomized it. In fact, it turned out that just telling the intern was plenty good enough. It's not like the attendings were going to their interns and saying, did you order that blood thinner? And so it worked just as well. And, and we dropped the number of alerts dramatically because we just turned it off for people. So we paid close attention to that. We paid close attention, as we talked about earlier, to what time or at what point in workflow we provide the alert. So our flu vaccine alert, we've been working on the flu vaccine alert for like 10 years. So we started at 23 times per patient per day. We're down to 1.2 per hospitalization now. But part of that is because, we were busy getting rid of those stupid ones. And then we were trying to think about, okay, well, what time during hospitalization should we show this? Because it was set up originally at every time they touch the flow sheet, because flu vaccine is really important. And maybe the more we talk to them about it, eventually they'll agree. And okay, that was not evidence-based, it turned out. What our nurses said to us actually was, this person is sick. They're in the hospital, they're feverish, they're feeling lousy. I'm not going to give them a flu shot. I'll do that right when they're going home. That's when, because that is a reasonable time. They're better, and that's a reasonable time to give a flu shot. So we realized, all of the alerting we were doing on day 1 and day 2 and day 3 and day 4, that was stupid, because no nurse was ever going to give a flu shot to somebody who was there, febrile with their pneumonia, on day 2. So we just turned it off until the last day of discharge. Okay, so we think about when to show it in the time of workflow. We think about who to show it to. And then, of course, we think about what information to put in the alert. This is why we spent all of this time building that spironolactone alert, to have all that information in it. Because what we found is that even when the desired activity would happen after the alert went off, very rarely did it happen from within the alert. So people would see the alert, they would make it go away, they would go check the chart, they would look it up, they would think about if they wanted to do the thing, they would talk to the patient, whatever, and then they would come back and do the thing. But of course, there's lots of opportunity for them to forget about it in the interim. So what we tried to do is build into the alert proper anything you might need to know. We just don't want anyone closing the alert and looking in the chart, because if we can keep them in the alert and satisfy them, then they are likely to do the thing. So these are all things that we're trying to do to just reduce the number of times these alerts pop up, because what we want is for a person to act on it the very first time, and then it never shows up again. And then, of course, the final thing is we need to make sure it shows up for the right people. And so we spend a lot of time on the algorithms behind there. How can we make sure all of the exclusions are pre-built in so it just doesn't show up? How can we make sure that the evidence is appropriate for this person? And does this institution agree with that evidence? Are they likely to act on it? And so on.
Great. Hi there. My name is Maria. I'm one of the intensivists in the pediatric ICU, and thank you all for everything you've shared today. My question actually piggybacks on that, and thinking about learning health systems are often academic medical centers that have trainees and learners of various parts of their education. And how do we help train the trainee to transition between learning health systems, and thinking about if I'm in a residency program that has these EMR-based either clinical decision tools or alerts that fire, and I go to a fellowship program that may not have that, how do I know that I was part of a learning health system that incorporated those? And I think drawing more awareness to the trainees that are part of these systems.
We actually get this objection a lot to putting alerts in. People will say, well, if you do that, then they'll just become dependent on it, and then they won't learn to think on their own. or conversely, we hear this if we talk about randomizing. Well, if you don't show it to half of them, and then they'll think that there is no need because they're not seeing an alert, whatever. So this is a challenge. I don't really know the answer to that, except that we should all be learning health systems, and that is not an issue. We involve trainees in almost all our projects, though. First, because they have really good insights, and second, because we want them to learn. So that's one thing, is just to make them aware. So, it's like when you learn a new word, then you see it everywhere, right? So if you teach somebody, hey, this institution might or might not be intentional about this problem, then they'll notice, oh, there's an alert for this, or there isn't an alert for that, or whatever. And then if you go somewhere else, they will notice the absence of it, perhaps, rather than just kind of taking it for granted and then not noticing. We could have some national standards, but that seems like a little much to ask for.
The concept of learning health system is really not part of education. I don't know how many clinicians, physicians out there, if you could raise your hands, if you heard the word learning health system in medical school or residency. You're right, same here. So any difference in your institutions in terms of, so tell us a little about that.
I'm not involved in the medical education, so I actually have no idea what's going on at Utah. We do have some really cool programs for, I mentor a person in what's called our STAR program, which I never remember what it stands for, but it's basically exposing residents to research during residency. And so it's really neat where they get, their first 2 years, they have a 3-month research block. And then in your third year, a 6-month, where you're only doing 1 day of clinical practice during that block. So it's really nice for them to get really into a project, or, of course, write a paper or do something like that. And I do have my STAR mentee is on our clinical practice board for this big P50 center that is early childhood mental health. And that is what she is, a pediatrician, and that's what she wants to study. So we have her both contributing to the design of the project, giving us input as an advisory capacity. And she's working with 2 of our seed projects on actually executing the work and writing the papers. So it is, and ours is a learning health systems project. So she's getting exposed that way. I've never asked her if she had any other exposure or if it comes up at Utah at all. My guess within our pediatric group is it's probably not something that's emphasized.
So for years, several years, I was asked to give a lecture about health systems to the third-year medical students who are rotating through medicine. And so I would go and give what I thought was lovely lecture about health systems, and it would get just dismal reviews, like terrible reviews. They hated it. I say this with all humility. I came to understand that it was because these are third-year medical students, and what we are doing with third-year medical students is we are teaching them pathophysiology and disease recognition and how to take care of the person in front of you. That's all that is the point of medical school, right? And so it was very hard to get them to take a step back and understand the impact of systems. So I changed the whole lecture. And what I did instead is we spent half an hour on delirium. I was like, let me give you a case. We've got this old lady. She's hearing voices. She's, waxing and waning. And they're like, okay, delirium. I was like, yes, excellent, delirium. Okay, what are the causes of delirium? And we go through the causes of delirium, and they would say UTI, and they would say medications, and they would say, infection, and lack of sleep and all this stuff. I was like, yes, excellent, good job. Okay, now you are the physician manager of a unit, and your unit has a higher rate of delirium than the unit next door. Why is that? And actually, they were immediately able to come up with, well, maybe your unit is more crowded. Maybe your unit has older people. Maybe your unit doesn't have pocket talkers for, deaf people. Maybe your unit, doesn't take urinary catheters out as much. They instantly got to systems. Because I was trying to pitch it in a clinical scenario that they understood how to think about. And so now that is sort of the way in which I am trying to approach training for the junior trainees among us who just haven't had an opportunity to understand how systems matter. Just last month, I was asked to give the institution's first learning health systems lecture to the first year medical students. Like, that was even worse. They don't even know delirium. So I tried to, again, did it all with case stories and tried to sort of get them to think about it that way. But that is like the 1 hour that they get. And then, the like 1 hour during their medicine rotation. So this is not deeply embedded into our curriculum still.
Actually, that jogged a memory. So I do guest lecture in a course that I think is third year medical students, and it's implementation science. So it's not learning health systems specifically, but I'm really close friends with the instructor, and I said, like, how should I tailor this? Like, I can't clearly do like all of implementation science within an hour and a half lecture with discussion time, and he said something very similar. He said, just help them understand how implementation science incorporates system factors and system thinking into overall effect, essentially. And so I take them through like REAIM, where it talks about if you can't reach a lot of people, if you do with low fidelity, if you have low adoption, if you can't sustain, your overall benefit at the hospital level or at your population level, you can just look at the dramatic decrease. And they all do get it. Like, and you can almost see like a light bulb click for some, because it's not the typical way they are thinking as medical students in that way. So that has been very interesting, and we get so much back and forth discussion. I mean, I never get the blank faces. It's like, again, it is like that. Oh, yes, there are all these other things that influence how I work and if my patients are going to get better. And they don't really think about it as a thing that you kind of can then perturb the system or you can change the system. But it starts to kind of plant that seed that, hey, this isn't only about what I do directly or what the patient does when they leave and factors at home, but it actually is like how the system operates and the constraints that I have to work within.
So I've got a question, and I really appreciate all the conversation today. And one of the things that strikes me as neutral, not positive or negative, is that a lot of this is driven by MDs. MDs are nowhere near the majority of the only type of providers in an academic health system. And in fact, the hospital is not the only setting in an academic health system. And so as we think about an LHS as what it could optimally be, I'm curious what your thoughts are on moving beyond the acute care hospital, moving into inpatient rehab, moving into your step-down facilities, moving into assisted living and skilled nursing facilities, all these places where we spend a buttload of money that could really pull some levers. But I'm curious your thoughts on why we don't see that, how we could see more of that, and some strategies to really expand what an LHS could be.
So I just want to say that I'm doing a major project with our inpatient rehabilitation unit in Chelsea Hospital right now. And we've done a lot of projects with our physical therapy team. So you're 100% correct. We talk a lot about there's a lot about the inpatient setting because a lot of exciting things happen there. But there's plenty of work that goes on outside as well.
And I've mentioned, most of my work in this area is primary care, and especially working in community health, most of the folks are not pediatricians or family medicine. They're actually advanced practice providers. And then, thinking about complex implementation challenges, like things like the pediatric hypertension guidelines are a really good example that about half of the steps are done by nurses. And so, even if it's MD driven as like an idea or like the identification of the problem, you're going to have to get all those other groups to change. I do a lot of pre-visit screening stuff too. That involves front desk staff. It involves the IT team. It involves schedulers. I mean, you end up like in primary care, if you're doing something that goes all the way from basically screening and identification to diagnosis, referral, and treatment, that's all sort of housed. And I do a lot of integrated behavioral health, so that is really what's happening. You are touching almost everyone in the system. It's a really interesting way to work. But primary care is definitely not as sexy as some of the issues that are happening in inpatient, and also they're not costly. Like that's another reason why I think the focus on practice variation and quality metrics within those settings would get a lot of attention is they're closer to potentially having death and things like that, and they're also very expensive things for patients, for insurers, and for the hospital.
Yeah, also, I just want to say the concept of learning community really ideally brings together the whole team. So in an inpatient rehabilitation learning community, we have 10 different disciplines. And that's really how a learning community functions best. if everyone's there. The physicians are often the lead. That just seems to be the model we see in a medical center. It doesn't have to be that way. Okay.
Oh, yeah.
Question?
Yes, Abby Bretzen again from the Injury Prevention Center here, and thank you all for your perspectives. I'm learning so much, and what stuck with me from this specific panel is what Dr. Hurvitz said, that there's many people probably operating a learning health system that don't know it, or doing implementation science that don't know it, and that's what I'm realizing I'm probably doing. So do you have any advice for early career investigators that are trying to set up a funding line in this realm of next steps that we should be doing when we're realizing we're probably working in this realm?
Oh, you're not going to like my answer. Well, I do, we actually made a comment like this earlier too, that there are a lot of folks who do practice change and do implementation research without being implementation scientists or being, or even having like classical training in that. I think in order to, unfortunately compete in NIH funding and things like that, you at least have to apply the same methodology, potentially have an implementation science expert on your team. That's another thing that I think, early career people forget a lot, is that once you get to the R01 level in particular, it's the team. It's not you. You don't have to be the expert in every single thing, just like you're not expected to be like a biostatistician for a super complex, study design. They want an expert to do that. It's very similar. So at least being able to learn the basics. I think if you are doing it, you see it so much easier, and you learn the information because you're already basically applying it. You just didn't have a name for it before. I can't remember who said that, but there was one of my colleagues actually said the first time they ever went to the D&I conference, and they were like, I don't know why I'm here, basically, and they weren't even presenting. And they sat through the whole thing, and they're like, I'm doing D&I. I just didn't know all the fancy words to put to all the stuff that I do. But unfortunately, to get funding, you kind of have to at least, get somebody who can help, add that shine. And it's funny, the same person who won't call himself an implementation scientist, who's been doing implementation research for 3 decades, that's exactly what he says. He says that he writes the grant the way that he would write it, and he sends it to his implementation scientist, or to me sometimes if I'm on that project. He says, put the IS sheen on this for me. And that's all it is. It's really like, what's the right model for me to use? Am I operationalizing these outcomes appropriately? And it's so funny, is he'll put something in how many times have we linked somebody to this? And I'm like, that's your reach rate. It's that simple, but just knowing what the terminology is such a huge deal. But yeah, you just be around implementation scientists, and if you have opportunities to take courses or go to workshops, that kind of stuff is always very helpful too.
There used to be, the NIH used to run this 5-day implementation science course. I used to send most of my trainees to it. I haven't seen it around in a while.
Ended in 2020.
Yeah, see, I'm old. But I think some of the materials are posted, or at least I used to have all of them, and I think they're still posted.
So the Tide Dirk program is, which it's focused on cancer examples, but everything is applicable to all implementations. It's very methods focused.
Yeah, I think that's a good resource for just learning the lingo. I am not a card-carrying implementation scientist, I feel like, because I don't know all the language all the time. That matters, though. JD's absolutely right here. But you can learn that through some of these trainings.
Well, unfortunately, we have to bring this to a close.
We do.
So I want to give each of you maybe another minute or two, if you'd like to give Michigan Medicine, University of Michigan, some parting words about what we can do to keep growing ourselves as a learning health system and implementation scientists.
I think you guys are, leading the country in a lot of ways in this. Having, a great implementation science group, having a health system and a statewide. I was very surprised to hear about your statewide initiatives to do LHS, and that's unique, clearly. So yeah, keep doing what you're doing, honestly, in a lot of ways. But going back to our earlier comment too, it was like, it's not a yes or no if you're a learning health system. It's kind of where are areas that you can become a better learning health system. And so really focusing on those pieces. Really excited to be here and to be able to learn from Leora and to hear from all the folks here. Because like I said yes in part because I knew I would learn a lot by coming here and being around y'all.
Likewise. Paul Batalden, who used to be at Dartmouth and then moved to Minnesota, used to say all the time, every system is perfectly designed to get the results it gets. Every system is perfectly designed to get the results it gets. It is not an accident, whatever our readmission rate is, or whatever our quality, measure rate is, or whatever our community engagement rate is, or whatever. That's because of the way we've designed whatever our systems are. And the goal with the learning health system is to redesign the system to get different results. And I think that's what we're all aiming for here, and what most of you are working on, and what is already happening in to a large extent here and in many other places. I will only say that I would love to do more collaboration with all kinds of folk. I feel like we're all doing really interesting things and learning all the time, and could learn from each other. And I don't want to reinvent any wheels. I don't have to. So I hope that we all get to stay in touch.
Thanks so much to both of you.